Hello from Portugal. My name is Ana. I'm the clinical practice specialist in Sensing Future Technologies, the company that develops physiosensing. I want to start by thanking you for being here again and also for taking interest in this topic. And most of all, for helping us fulfill our mission of thinking about everyone in the world who suffers from balance disorders. So today's webinar title is Assessing Cervical Proprioception in Dizziness and Instability, the Cervical Joint Position Error Test. So the role of cervical proprioception in dizziness has long been surrounded by some scientific debate. But today we will address the surrounding controversy about this topic and take a balanced and evidence-based look at how cervical proprioception may fit into the broader clinical picture of patients suffering from dizziness. Okay, so I think we can start. Okay, so our mission, thank you once again for being here with us. So first things first, what is dizziness? We know that dizziness is a frequent complaint of in adults, and sometimes, or it's often used to describe different feelings. So to describe a sense of disequilibrium, disorientation, lightheadedness, some confusion, and also that pre-syncope feeling, such as in hypotension situations. The International Botany Society, which is a global scientific organization that brings together experts in the neurotology world, let's say, with the goal of standardizing definitions to improve diagnosis, communication, and research in vestibular science. So the International Botany Society defines dizziness as the sensation of disturbed or impaired spatial orientation without hallucinatory or distorted sense of motion. So it is a different feeling than vertigo, where there is in fact this distorted sense of self-motion. Okay, so it's not present in dizziness. Okay, so what is this relationship between dizziness and the cervical spine? Despite its clinical practice recognition, so it's highly recognized in clinical practice, this relationship is still debated and not fully consensual in the literature. So cervical dizziness is characterized by dizziness that is associated with cervical pain or any cervical dysfunction. So where the underlying mechanism of dizziness arises from a problem in the cervical region. So in other words, the definition requires a causality relationship where a cervical problem provokes dizziness. Okay. And again, despite its recognition in clinical practice, explained by the frequently encountered clinical scenario of a patient with neck symptoms and dizziness, so overlapping symptoms in whom no other causes for dizziness have been identified, and where the response to neck-directed therapy is very high. So it's very successful in decreasing dizziness symptoms. Despite all of this, there is still some controversial due to the absence of a specific diagnostic criteria or gold standard tests. So for now, cervical dizziness is recognized as a diagnosis or a syndrome based on exclusion. Okay? So what are the important considerations regarding cervical dizziness? So the first thing that we need to think about is the requirements. So again, cervical dizziness is strictly a diagnosis of exclusion. So clinicians must establish a temporal relationship between neck symptoms and dizziness, an history of an event, an injury of the neck, and the elimination of all other causes that may explain the dizziness itself. Okay. Another important consideration is that we need to think about if it's if there is in fact a causality relationship or it's just coincidence, because we know that both complaints are very common independently. So it's very common to find a patient with suffering from neck problems, and also quite common to have patients with dizziness. So this overlap in time might be coincidental, or they can be related. Okay. The last one that is also very important to consider is especially this is especially in situation in traumatic injury situations, like after patients after concussions, after whiplash injuries. So when we have a traumatic injury, head injury, we need to consider first the more frequent disorders that may explain the symptoms of dizziness and sometimes vertigo. It does not mean that the neck is not affected and it's not contributing for the symptoms, which likely is, but many times we also have situations as BBPV, labyrinthine concussions, and migraines, vestibular migraines after this kind of injury. And so we need to also focus on excluding this first, and if there are, of course, treat, and also if there's the need, address the neck. Okay, so these are important aspects to consider. Okay, so what do we need to rule out? These are just a few examples. Regarding vestibular disorders, the most common cause of vertigo and I would say the most frequent distractor would be benign paroxysmal positional vertigo, so the BPPV that I just mentioned. Why? Because in both BPPV and in cervicogenic dizziness, head movement, neck movement triggers symptoms. So we need to first rule out if there is any there's any questions or any vestibular disorders first, especially BPPV, after considering that is cervicogenic dizziness. Another disorder that can also be confused is a vestibular migraine, because in both situations, so migraine during vestibular migraine, there are symptoms of dizziness and also neck pain and of course head pain and neck pain. So it's a very similar temporal presentation as the cervicogenic dizziness. So it's also something that we need to take into account. Other dysfunctions and disorders that are not vestibular in nature, but they are also important to rule out, and they are like red flags, and if there's any of these are present, there's a need for referral. We have any vascular compromise. So conditions like rotational vertebral artery syndrome or any vertebral artery dissection must be considered, especially if symptoms are strictly positional. Okay, so also you need to test for this. Other situations such as autonomic abnormalities, such as hypotension caused by specific head movements or head positions where sensitive carotid sinus baroreceptors can be triggered, and then we have central disorders, and here's just one example, a brainstem compression due to craniocervical instability. So all of these are serious and should be considered before assuming it is cervical dizziness. Okay. So what is the link between dizziness and cervical proprioception dysfunction? So there are several pathophysiological mechanisms for cervical dizziness have been studied. One of the most researched and accepted pathogenesis for cervical dizziness is related to cervical proprioception dysfunction and a subsequent sensory mismatch. So first, what is proprioception? So it's what allows us to sense our body position. So joint position sense, joint movement. So we know if we remain with our eyes closed, if our arm is extended or flexed, at what range of position, and also the force applied in our body segment. So this sensory information is transmitted by receptors that can be found in the joints, muscles, and tendons. So, what what is different in cervical proprioception? It is in fact extremely well developed. So cervical proprioceptors, so these sensors are divided into joint receptors, muscle spindles, and Golgi tendon organs. It is important to notice that the human neck has an exceptionally high density of muscle spindles, particularly in the occipital muscle regions that detect precise head position and head movement. The joint receptors that are located in the cervical facet joints and discs, they act as joint limit detectors, okay, to sense where the joint position is. And also they do influence a lot muscle activity, so they are very important for stabilizing the neck during movement. Okay, so let's move on. So how is the cervical proprioception information used and for what purpose? We know that we need information provided by different sensory systems to be able to maintain spatial orientation, so we know where we stand in space and in relationship to our different body segments. And this includes head trunk orientation. So for head trunk orientation, we collect and integrate information from the somatosensory system, and here it is neck proprioception. So we can have information regarding our head position and head movement relative to the trunk. The vestibular system gives us information regarding head movement, so head acceleration in the angular and linear planes of movement, and also it gives us allows us to have a perception of where the gravitational vertical is, and where we are in relationship to this vertical. And finally, the visual system allows us to have a view on where we are in relationship to the environment. So these inputs are integrated and they are used in specialized reflexes to ensure the coordination between head, neck, and eye movements, contributing for gaze stabilization, head stabilization, and of course, body posture overall. Okay, so let us analyze in a brief way these reflexes. We are starting with reflexes that contribute for gaze stabilization. So the first and the most important one is, of course, the vestibular ocular reflex, the VOR. So it constitutes a reflex in which head movement signals from the vestibular system it triggers equal speed and opposite direction eye movements, and this allows us to maintain our vision stable during movement. It's like having a stabilizer in our video camera. And then in a less dominant way, the cervical ocular reflex also contributes for gaze stability. This reflex uses the cervical proprioceptive information from the neck and spine to sense again head movement, and it acts on the extraocular muscles as the VOR to also induce a compensatory movement and to keep our vision stable. So it's a complement. It assists the VOR on this task. For head stabilization, we rely on two other reflexes. So we have the vestibulo-colic reflex. So it uses the vestibular information from the inner ear to generate compensatory neck muscle activity, so to stabilize the posture of the head. Okay, so it uses vestibular information, acts on neck muscles. And then we have the cervical colic reflex. It uses neck proprioception information to act also on cervical muscles, assisting also the coordination of head and neck movements and contributing for head and neck trunk alignment. So they are all very important. So this is just a summary, a table with a summary of these reflexes. So we have the cervical colic reflex. The input source is the cervical proprioceptors. The output is going to be the neck muscles, and the primary function is to stabilize the head relative to the trunk using cervical sensory feedback. Then we have the cervical ocular reflex. So we have the input source, the cervical proprioceptors, acting on the extraocular muscles, assisting gaze stabilization during head motion, so assisting the VOR. Then we have the vestibular cervical reflex. It's going to use the cervical information, act on neck muscles for stabilizing the head during movement. Okay? And then the VOR. It's going to use the vestibular information. It's going to act on the extraocular muscles to keep our gaze stable by producing compensatory eye movement opposite to the head motion. Okay? So it's our main reflex for gaze stability. So as I already mentioned before, one of the most studied and accepted pathogenesis for cervical dizziness is related to cervical proprioception dysfunction and a subsequent sensory mismatch. So it is believed that a dysfunction in the neck proprioceptors can result in inaccurate signals that conflict with the information provided by the other sensory input coming from the eyes, the visual system, and the inner ear, the vestibular system. So this mismatch is thought to disrupt some of these important reflex pathways that I just mentioned. So for the cervical ocular reflex, which we already know that complements the VOR for stabilizing gaze, when there is a faulty cervical input, it may result in a suboptimal correction of eye movements, contributing to some feelings of dizziness and oscillopsia. So it may clash with the VOR. For the cervical colic reflex, faulty cervical proprioception information can activate neck muscles inappropriately, okay, causing excessive stiffness, an increase in muscle tonus, and asymmetrical responses. And it is important to think that this may also create a loop where abnormal muscle tension further distorts proprioceptive information, so worsening this mismatch. And finally, the vestibular colic reflex. So we can see that when the vestibular input says one thing and the cervical input says another, so the vestibular colic reflex and the cervical colic reflex may compete with each other, also clashing, leading to erectic head stabilization, increased neck muscle co-contraction, and a sense of head instability. Okay, so this is a brief explanation of these reflexes and how they can be impacted when there is faulty cervical proprioceptive information. And here are some known causes that may result in cervical proprioceptive input dysfunction. So we have trauma and pain. So we have whiplash injuries and concussions, and even chronic pain can damage cervical receptors and distort sensorimotor control, leading to long-term deficits even after the pain is resolved. The degenerative diseases, so inflammatory diseases, and I'm going to show you a study about this, where the inflammation and the growth of the new receptors in damaged discs can also be responsible for generating faulty signals that are going to mismatch with the normal vestibular and visual data. So this mismatch theory, and that muscle issues. So spasms or muscle fatigue can lead to hyperactive or hypersensitive muscle spindles. And this is specifically important in the suboccipital region, which we already know that contains a very high density of these receptors, which can also lead to erroneous, faulty input that is going to clash with the other sensory information. Okay? So acknowledging that this proprioception dysfunction and subsequent sensory mismatch as a possible pathogenesis for cervical dizziness. So the joint position error test comes as a potential clinical assessment tool for the diagnosis and evaluation of cervicogenic dizziness. So in fact, the joint position error is one of the most common tests used to assess neck proprioception. It measures joint position sense by evaluating the patient's ability to relocate their heads to a neutral position after active head movement without vision, so with eyes closed. Okay? So how do we perform this test? And I'm going to explain you with the inertial sensor because it's how you do it, but you can also perform it with a laser. The inertial sensor has advantages because it allows you to calibrate the system to match the patient's neutral position without having the need to adjust the patient's position or the position of the target itself. So how do we perform this? The patient should be seated 90 centimeters away from the screen with their back and feet well supported. The test is composed by 4 conditions of cervical movement. We test left rotation, right rotation, extension, and flexion. Each movement is repeated 3 times, so there is 3 trials for each movement, and at the end, the mean angle magnitude error is calculated. So we start by asking the patient to close the eyes and rotate their heads to the left as far as they can comfortably go, so without pushing it, and slowly to try not to activate as much the vestibular system and focus more on the proprioceptive information. After reaching this point, we tell the patient to rotate back to their initial position, and the patient should stop the movement when they feel that they are back at this initial neutral position. So at that point, we validate that position, and the error between this final position and the initial position is measured. Okay? So for cervical dizziness, an error greater than 4.5 degrees in head repositioning suggests a deficit in the accuracy of head and neck relocation. It was demonstrated that the test diagnostic accuracy depends significantly on the chosen threshold for a positive result. So when a positive result is defined by an average error above 4.5 degrees, the test maintains a balanced profile, so showing a specificity of 75% and the sensitivity of 72%. However, if the threshold is broadened to include any single position error that is greater than 4.5 degrees, the sensitivity increases to 92%, which means that it successfully catches almost all cases of dizziness, but the specificity drops to 54%, so which means that we are going to have a lot of false positives. Okay. Overall, the test is considered to be a good test to assess neck proprioception, especially related to sensorimotor dysfunction that is associated with cervical dizziness. Okay. Other clinical conditions that also show, and also in the literature show an increase joint position error, and that are also accompanied by additional indicators of balance impairments, are whiplash associated disorders. Okay, so we already spoke a little bit about this. So patients with a persistent pain after acceleration and deceleration injuries frequently show increased joint position errors. And they also demonstrate altered balance responses, these articles supports the idea that abnormal cervical input can negatively influence postural control. For rheumatoid arthritis, so I mentioned inflammatory conditions a few slides ago. So this study was very interesting and is quite recent. Individuals with rheumatoid arthritis show significantly impaired cervical proprioception measured by the higher joint position error. And they found out that these proprioceptive deficits were also linked to poor postural control. And this was reflected by an increase in center of pressure related parameters. So they used also here posturography analysis. And for older adults over 65, the study showed that they demonstrated a higher joint position error values, and that was strongly associated with poor balance performance and reduced functional mobility. So here they tested the time up and go. And they also found out that those with greater joint position errors also present worse results in the limits of stability assessment. So it's very, very interesting studies. So despite of the lack of a full consensus on this topic, it is important to recognize that a positive feedback loop exists between dizziness and cervical dysfunction. So this likely explains why many individuals with dizziness show improvements when cervical impairments are addressed during treatment. Okay. Patients, and we know this, that patients experiencing dizziness from any cause frequently adopt this head-on trunk stiffness to avoid moving the head and triggering symptoms. So as a consequence, this prolonged stiffness leads to neck problems such as muscle spasms, muscle fatigue, pain, which, as we already went through, can further impact cervical proprioceptive input, which might exacerbate dizziness. So we can think about this as a vicious cycle where dizziness contributes to neck stiffness and pain, and neck stiffness and pain contributes back to further dizziness. So what is the best treatment for cervical dizziness? Research consistently highlights, I apologize, a multimodal approach as the most effective strategy for managing cervicogenic dizziness. So this approach combines manual therapy, pain management, and sensorimotor exercises to restore cervical mechanisms to reduce pain and improve neck proprioception. The goal is to interrupt the feedback loop, to interrupt this cycle. So by reducing muscle spasm and restoring normal joint mobility, the therapy, this target therapy stops the flow of faulty signals sent by the cervical proprioceptors. So this approach is frequently successful because it addresses half of the loop regardless of what started. And this is why so many people with dizziness get better when the neck is also addressed during treatment. Okay? So regarding the sensorimotor exercises, this includes proprioceptive exercises. So this type of exercises require and they target the fine control of neck movements, addressing both the afferent input and the efferent output. So for the head repositioning accuracy, we can perform the neck relocation exercises, such as by having patients again practice moving their head away from the neutral position and then getting back to the neutral position without the visual information. So In other words, you can perform the joint position error test, but as an exercise, as training for recalibrating the sense of joint position. And then we have movement and training exercises, where the patients perform exercises of fine neck movements such as tracing paths, circles, shapes. Also, there you can also use a laser to do this, or if you're using technology, you can also use an inertial sensor, which again has the advantage of being able to calibrate the position, the sensor to the neutral position of the patient, and being able to parameterize the exercises to the patient itself. Okay. Other exercises that can be part of the plan are eye-head coordination and gaze stability exercises. So these exercises link the proprioceptive system with the visual and the vestibular systems. So we can think about the typical VOR exercises where we lock our eyes on a target and we move our head in different planes of movement. Or for eye-neck coordination, we can perform voluntary eye movements followed by voluntary head movements, such as doing a saccade and then following with a head movement. And then, of course, exercises to work on balance. So as the patient progresses, we can perform these exercises on top of unstable surfaces to further integrate the sensory inputs. We can also add cognitive tasks to this type of training. Research is very clear on this. There are a lot of benefits by adding a cognitive task to this type of exercises. The video is also showing this kind of exercise, and in this case is a memory game, a sequential memory game. Not now, but in a second or two, where the patient needs to memorize the colors and the sequences of colors that appear on the screen and have to replicate the movement with their center of pressure. It's the Simon Says game that I think we all played in kids. Okay. So the clinical takeaways from today's webinar are here. So the first one is remember the requirements. This is based on research that is available now. I hope, and we all hope, that we will have more knowledge on all of this. We know that the vestibular sciences, we still don't know a lot, and hopefully there will be more research to try to help us out navigate all of this. But for now, the requirements is that the cervical dizziness is strictly a diagnosis of exclusion. So there must be a temporal relationship between neck symptoms and dizziness, a history of neck injury or any other traumatic event, and all other causes must have been eliminated. So rule out if BBPV and vestibular migraine are the vestibular disorders that can be confused or maybe more easily with cervical dizziness. So be aware of it. Remember coincidence versus causality. So besides establishing this temporal relationship between the neck symptoms and the dizziness symptoms, since neck symptoms and dizziness symptoms are very frequent independently, we need to consider if this overlap is just a coincidence or is there any causality relationship. Anyways, as we saw on the feedback loop, the positive feedback loop, when we have patients suffering from dizziness from any other causes, a lot of times they end up developing cervical problems, and they can also influence the symptoms, so worsening the symptoms of dizziness. The distractor effect. This is especially for traumatic injuries of the head and neck. Don't forget to rule out the more frequent problems that arise often from this type of injury that normally or they are frequently vestibular in nature, such as BPPV, migraines, and labyrinthine concussion. But treats the neck, so break the cycle. Consider this multimodal approach by reducing muscle spasms, restoring normal joint mobility. We can impact positively the quality of the cervical proprioceptive information, and at the end have a positive effect on the rehabilitation of a patient suffering from dizziness. Okay, so I will leave you with some very recent research on this subject. So this webinar is going to be uploaded on YouTube, and then you can also consult the list. There are some very interesting new articles from 90 to 100. 2024, 2025. I'm not sure if there's any more recent than that, but you can then take a look into it on YouTube. And I'm also leaving you my email address and our website here, so you can explore our complete range of solutions for balance assessment and rehabilitation. You will find systems designed for vestibular rehabilitation, others that are more focused on the physical rehabilitation, and also a system that is an entry-level technology for beginners. If you would like to learn more, you feel free to get in touch at any time. You can also follow us on social media to stay updated on our latest developments and events, and also educational contents, because we also have a big list of webinars, ebooks. We have also our scientific publications with our systems there, so you can explore everything. And once again, thank you for joining us today. I hope you enjoyed. I hope you find it interesting. It's a very interesting topic. It's still a bit, I would say, confusing, because there is not still a full consensus on this. But I think with in the next years we are going to know more, and we will be able to better help our patients. So thank you once again, and I will see you in our next webinar.